Hello, and welcome to our CLP session, Advancing Knowledge, Developing Careers, and Strengthening Community Around Social Justice in CL, being presented by myself, Abisa Kandai, my colleagues, Dr. Mira Zain, Dr. Diana Robinson, Dr. Adrian Taylor, and Dr. Kayla Bebahani. For the purpose of this presentation, I have no disclosures. Our learning objectives today will be to apply principles of social justice to CL psychiatry, to critique CL psychiatry patient cases from a social justice perspective, and to describe ways to advance social justice through clinical, research, and educational avenues. A brief outline of our talk today. First, I'll be going over key principles in social justice. Then we'll be hearing 4 cases where we apply social justice principles. So case 1 will be Dr. Robinson talking about a woman with IV heroin-related endocarditis needing valve replacement. Case 2 will be Dr. Mira Zain talking about an undocumented Guatemalan male admitted for TBI. Case 3 will be Dr. Taylor talking about a Black Haitian male with schizophrenia shot by the police. And case 4 will be Dr. Bebahani talking about a woman with sexual trauma needing stem cell transplant from her abuser. At the very end, we're going to be having a panel discussion and discuss ways to advance social justice in CL based on some questions that came up in our ongoing survey of psychiatrists in social justice. So, brief overview, why is social justice important? The term is thrown around a lot, certainly becoming more popular nowadays, but it's important to understand that patients with psychiatric and substance use disorders are underserved in our general medical system. At the same time, minoritized and underserved populations are underserved in our mental health system. Why CL psychiatry? Like, why are we asked to be involved? Well, we have an embedded role within the larger healthcare system, so we can be amongst the system itself and see things from an inside perspective. We are also the entry point for vulnerable patients into the mental health treatment system. And lastly, we have a lot of opportunities, given our embedded role, for advocacy and education of our physician peers and healthcare staff. So some key principles I'm going to be going over briefly right now, and then discussing further in the cases. Social justice, social determinants of health, health and healthcare disparities, structural vulnerability, stigma and implicit bias, intersectionality, and structural competency. So what is social justice? So the classical definition of justice is action in accordance with the law, but a more updated definition of justice is the idea of justice as fairness, which was brought forward by Rawls in a Theory of Justice from 1971. Some common definitions of social justice include justice in terms of the distribution of wealth, opportunities, and privileges within a society, or fair and just relations between the individual and society. Some related forms of justice you may see are distributive or economic justice, which is the idea of a fair share or a fairness in distribution of rights and resources. You may also see procedural justice, which is a fairness in processes or fair play. Retributive justice, which is fairness in the punishment of wrongs done. And then restorative or corrective justice, which is much more victim-driven and based on restoration of what was gone wrong. Now, a related term is social determinants of health. This is a term that's used by the CDC and other governmental agencies that refers to the conditions in the environments where people are born, live, learn, play, and age that affect a wide range of health outcomes and risks. There's 5 key areas we talk about when we talk about social determinants of health. Health and healthcare, so coverage, provider availability, quality of care. Education, so both early and higher education and literacy rates. Social and community context, so talk about social integration, support systems, and discrimination. Neighborhood and built environment, so actual physical environment itself, like housing, transportation, food access, safety, and then economic stability, so food and housing security, income, employment. And these are all thought to affect healthcare outcomes. So related to that are health and healthcare disparities. So a health disparity is there's a difference in the burden of illness, injury, disability, or mortality experienced by one group relative to another, versus a health care disparity is differences between groups in insurance coverage, access to and use of care, and the quality of care. For both health disparities and health care disparities, it's important to note that these differences are disproportionate, preventable, and they're closely linked with social, economic, environmental disadvantage. So those social determinants of health we were talking about earlier. When we think about disparities as a system, then we start talking about structural vulnerability. This is the likelihood of encountering difficulties or threat due to your location in hierarchical social order that's embedded in diverse networks of power relationships and effects. So basically, systems of healthcare and health disparities can lead to a person being structurally vulnerable. And these are related to ideas of structural violence and structural racism. Now, changing gears a bit, stigma, we hear this term a lot, but what it means is a set of stereotypes or negative views attributed to a person or groups of people when distinguishing characteristics or behaviors are viewed as different from or inferior to societal norms. And this can be based on illness, disability, race, gender, sexuality, religion, culture. So there's 4 types of stigma we generally talk about. There's social stigma, which is interpersonal between people. There's structural stigma or the institutional stigma associated with individuals. Self-stigma, which is internal, like what people feel about themselves. And then stigma by association. So that's with relationship with the stigmatized, like family healthcare workers. And we've all experienced it, like when you come onto the floor and we tell people the consult psych team, it's like, oh, the psych doctors are here. That's stigma by association. A related but separate concept is implicit bias. And so these are attitudes or stereotypes that affect our understanding, actions, and decisions in an unconscious manner. So they're both favorable and unfavorable assessments based on aspects like race, ethnicity, age, and appearance, and they tend to favor our own in-group. And again, the important idea is that these are unconscious, these are learned over time, and we oftentimes are not formally aware of it. The good news is that this can actually be formally tested. There's a test called implicit association test, which measures the strength of these associations between concepts and evaluation of stereotypes that reveal our hidden or subconscious biases. So in the example on the right, we associate a black or white face of an individual with the word good or bad. So the speed with which we associate black and bad and white and good versus black and good and white and bad constitutes an implicit bias that you may have towards Black individuals. So intersectionality, trying to bring all this together. This was a term first coined in 1989 by Professor Kimberly Crenshaw, and that describes how race, class, gender, and other individual characteristics intersect with one another and overlap in privilege and oppression. And the classic example is a woman facing barriers both due to her being Black and being a woman. It becomes a sort of double whammy. And then very lastly, a term that brings everything together is the idea of structural competency. We're all familiar with the term cultural competency, but structural competency takes it one step further. This is the trained ability to discern how a host of issues defined clinically as symptoms, attitudes, or diseases actually represent the downstream implications of a number of upstream decisions about healthcare, food delivery systems, zoning laws, urban and rural infrastructures, even the very definitions of illness and health. So really taking cultural competency, which is the individual and their culture, and thinking about it more from like a systems perspective. This was actually developed by Dr. Jonathan Metzel and Dr. Elena Hansen, who are both 2 psychiatrists, and they really focus on 5 core competencies. 1, recognizing the structures that shape clinical interactions. 2, developing the extra clinical language of structure to envelop this. 3 is rearticulating cultural presentations in more structural terms. 4 is observing and imagining structural intervention. And then 5, developing a sense of structural humility. So again, this is a very quick whirlwind through all these social justice terms. And now I'll turn it over to my colleague, Dr. Diana Robinson, to take us for our first case.
Okay. Hi, everyone. My name is Diana Robinson, and I'm going to be presenting case 1 on the impact of opioid use disorder on a woman's clinical care. This case is going to demonstrate and apply some of the principles of stigma and health disparities that we just learned about. I have no disclosures to report. So Ms. C is a 47-year-old Black woman with a past medical history of depression, asthma, chronic back pain, and obesity, who presented at the emergency department of a tertiary care hospital with several weeks of fever, malaise, and shortness of breath. She was admitted to medicine for sepsis due to infectious etiology and was started on intravenous antibiotics and was undergoing a cardiac workup for a new murmur. Psychiatry was consulted on hospital day 2 for the evaluation of the patient for wanting to leave against medical advice. The primary team was concerned that the patient was medication seeking for opioid analgesia and made comments about her being a frequent flyer. It seemed like they were frustrated with the situation. On the initial evaluation, Ms. C stated that she wanted to leave because she was in pain. She also said that she hadn't been sleeping well and had been very anxious recently and reported trauma exposure as well as traumatic nightmares that had worsened while being in the hospital, as well as recent avoidance and hypervigilance that made seeking healthcare more challenging. She was aware that she was in the hospital and she was there because of an infection, as well as she had understood the risks, benefits, and alternatives of leaving against medical advice. She wanted to leave because of the poorly controlled pain in terms of what was leading to her wanting to leave. In terms of her past psychiatric history, she wasn't currently in psychiatric treatment and had been seen by a primary care doctor in the past and was treated with paroxetine for depression. She had no unknown other past psychotropic medication treatments. In the past, she'd had a remote psychiatric hospitalization for suicidal ideation and had never had a suicide attempt or violence against others. In terms of substance history, she has a 1 pack per day use of tobacco, drinks about 1 to 3 drinks less than once per month, and in the past had used cannabis and denied any other current use, but per hospital record review, there had been previous urine toxicology screens that were positive for opioids and cocaine. Social history was pertinent for unstable housing. She was currently living with a friend and being divorced with 2 children that were living with her mother, who she was estranged from. Her father is deceased, and she also has a brother and sister that she's estranged from. In terms of education, she dropped out of school in 10th grade and wasn't currently working. She'd been incarcerated in the past for possessions of illicit substances. And as mentioned before, had a previous trauma history of sexual abuse in childhood, as well as concern for intimate partner violence as an adult. Finances were strained and she was uninsured. In terms of family history, she had a pertinent family psychiatric history of a mother with depression and anxiety, a strong family substance history, and a brother and uncle with opioid use disorder, as well as family history of alcohol use disorder, and no family suicide attempts or completions. Surgical history pertinent for L3 to 4 laminectomy infusion procedure. And while in the hospital, she was receiving intravenous vancomycin and Zosyn and received several PRN doses of pain medication and her inhaler. Review of systems was pertinent for back pain, fever, and diarrhea. And on mental status evaluation, she was irritable, increased psychomotor activity, fidgeting around, rubbing her joints. Her thought process was linear, but she was focused on pain. She did not appear to be responding to internal stimuli. Her mini-mental was 29 out of 30, and she was alert and oriented to person, place, time, and situation. On physical exam, notable for tachycardia, as well as elevated temperature. General, she was diaphoretic, also had dilated pupils, rhinorrhea, and lacrimation. And as mentioned before, she has a new onset grade 3 systolic murmur heard loudest on the lower left sternal border and increased vowel sounds on GI exam. In terms of labs that we had access to at this point, she had leukocytosis, as well as a current urine toxicology screen on admission positive for opioids and cannabis. Blood alcohol was negative, and as shown, chest x-ray was abnormal, and blood cultures hadn't grown out yet. In terms of outcome on this initial evaluation, she appeared to be in opioid and nicotine withdrawal and concern for opioid use disorder, even though she had not disclosed that she used opioids. Also pertinent for post-traumatic stress disorder. And at this time, even though she had capacity to leave against medical advice, that after using shared decision-making and discussion about the patient's goals of care and how we could improve upon her pain control, the patient was willing to stay to give this an opportunity. We also provide symptomatic treatment of opioid and nicotine withdrawal and symptomatic treatment with replacement therapy. So on the next day, we came back to see her, and now that her pain was better controlled, we were able to engage in motivational interviewing and talked about her progression of back pain starting after a motor vehicle accident, receiving prescribed opioids after surgery, and developing tolerance and escalation of use, eventually to intravenous use, and had numerous symptoms of opioid use disorder. So she met criteria for opioid use disorder moderate. We talked about medication-assisted treatment for opioid use disorder and starting that while in the hospital, and she was interested. Also, her cardiac workup with a TTE showed vegetations on the tricuspid valve, and ejection fraction was abnormal, and she was diagnosed with endocarditis. Blood cultures came back with gram-positive cocci, and her clinical opioid withdrawal scale was pertinent for a score of 24, so that's in the moderate category, high into moderate. After more discussion on medication-assisted treatment in terms of buprenorphine versus methadone and naltrexone, she was interested in starting buprenorphine, and she was induced that day on buprenorphine naloxone 5-1 BID. So she was diagnosed with opioid use disorder, and over the course of the rest of the hospitalization, that buprenorphine was titrated. She's also started on treatment for post-traumatic stress disorder, and from a social determinants of health perspective, that we worked with the patient to reach out to her family that she was estranged from for additional support, as well as a place to go after discharge and additional support getting to her follow-up appointments, as well as social work assistance with accessing insurance. So after 6 months, the patient was able to engage in opioid use disorder treatment at the Bridge Clinic, and psychiatry and psychology was able to transition to the community, and she didn't have any substance relapses known to date. From a cardiac perspective, that initially she was not presented with the option for a valve replacement therapy due to the primary team being concerned that because of active opioid use disorder and poor follow-up in the past, that she wouldn't be able to have a good treatment outcome. But because of engagement with CL Psychiatry and multidisciplinary meeting and planning, we're able to come up with a plan together in terms of how to make her a better candidate. And she did receive a valve replacement, and the outcome from a cardiac perspective was also positive, and she was able to engage in her follow-up. In terms of stigma, so this case demonstrates stigma. So as Chandan mentioned, stereotypes are negative views attributed to a person or groups of people with their characteristics or behaviors being viewed as different or inferior compared to societal norms. And we know that people with untreated substance use disorders contribute to tens of thousands of deaths per year and impact the lives indirectly of many more. A review of 20 studies since 1999 showed stigma associated significantly with substance use in non-clinical samples, and showed that the public holds stigmatized views towards people that use substances, showing that they're dangerous, unpredictable, they're unable to make their own decisions, there's perception of this, and they're blamed for their own condition. So we have a lot of work to do from a societal education perspective, as well as there's higher stigma towards substance use disorders, even compared with other psychiatric disorders. So if you have both, then there is an additional compounded effect of this. On a structural level, that this can impact willingness of policymakers to allocate resources for substance use disorders, and can decrease the likelihood of medical providers to screen for and address substance use disorders. There's also a dual challenge, as I mentioned, of people with mental illness as well as substance use disorders that can compound the difficulties and disabilities that result from these diseases. So for Ms. C, she had a history of post-traumatic stress disorder from a substance use perspective, opioid use disorder, cannabis use disorder, and tobacco use disorder, as well as gender and race and class. She also had chronic medical problems and acute medical problems in terms of her cardiac status, as well as the medical system was impacted by the perception about what treatment she was able to get. And instead of engaging in a discussion of how to make her a better candidate, came to a premature closure in this case about what treatment she was offered. So this structural stigma led to further reinforced self-stigma in this case. In terms of health disparities for people with substance use disorders, racial and ethnic underrepresented minorities have worse outcomes and suffer negative drug-related consequences, particularly higher rates of bloodborne infections such as hepatitis C and HIV. These are especially bad for people that are Black, Latinx, and Natives. There's a greater substance-related disability and premature death in the Black community compared to other racial and ethnic underrepresented minorities. Whites also have significantly greater rates of alcohol use compared with others, but they have lower worsened alcohol-related illness and negative sequelae from alcohol. And specifically, the Latinx community has a higher rate of DUI-related fatalities. There's also higher related rates of cocaine overdose deaths among Black and Latinx communities compared with whites, and higher rates of involvement within the legal system. In terms of overdose deaths, that you can see here that from 1999 to 2015, that although the number of opioid overdose deaths have been increasing in all populations, that this impacts some more so than others in terms of Native populations and the white community. Health disparities in terms of accessing care for substance use disorders shows significant risk factors in terms of gender, housing status, poverty, psychiatric history, stigma, and a lack of resources. And there are punitive laws specifically for substance using women with children that can make it even more difficult to access child care, that can make it difficult for women to seek care and to be able to access evidence-based treatment for substance use disorders. We know that racial and ethnic underrepresented minority populations in the US are less likely than whites to seek mental health treatment, as well as even for controlling for access to care through the Affordable Care Act, there is less engagement of populations in substance use treatment. So we have a lot of work to do where we can be able to improve outcomes for patients with psychiatric and substance use disorders. Now I'll hand it over to Dr. Mira Zain, who will present case 2.
Hi, my name is Dr. Mira Zain, and I am a clinical assistant professor and consult-liaison psychiatrist at Stanford University. I will be talking about a case of traumatic brain injury in an undocumented migrant worker to explore the concept of structural vulnerability. I have no disclosures. In this section, we'll be using a case of TBI in an undocumented migrant worker from Guatemala to explore the concept of structural vulnerability. We'll start with going over the case, then explore the definition of structural vulnerability and apply it to TBI and to the specific case of a Latino migrant worker in the US. We'll then return to our case and apply these concepts to how the patient received care and wrap up with a brief look at how CL psychiatrists can apply structural vulnerability concepts in practice. So let's start with our case. MT is a 23-year-old man originally from Guatemala who came to the US as an undocumented migrant and has been working in California's Central Valley as an agricultural laborer. He had no past medical or psychiatric history. He was crossing an intersection on his motorcycle when he was struck by a vehicle at approximately 35 miles an hour. His Glasgow coma scale was 4 when EMS arrived and 10 in the emergency room. On initial scans, he was found to have multiple intracranial hemorrhages. We can see some of these on the right, multiple fractures throughout his body, as well as pulmonary injuries. Also seen at the right, his MRI brain showed diffuse axonal injury. He lost consciousness again with interval hemorrhage worsening, was intubated and admitted to the surgical intensive care unit. He was in the SICU for the first month after admission and required multiple medications to manage his post-traumatic delirium. As MT medically stabilized and was more awake, he was noted to be impulsive, disinhibited, and intermittently agitated. In addition, he had significant neurocognitive deficits with post-traumatic amnesia persisting for weeks after his initial accident, dysarthria, and motor and coordination impairments. I'm looking at the figure on the right. MT meets criteria for a severe traumatic brain injury due to his initial Glasgow coma score of less than 9, his post-traumatic amnesia lasting for weeks, and a prolonged loss of consciousness after initial lucidity. Severe TBI in particular is associated with lasting cognitive deficits in up to 80% of individuals and also has a higher risk of acute and chronic neurobehavioral symptoms post-TBI. Thus, for severe TBIs, having rigorous post-injury rehabilitation becomes crucial to recovery. Now, because MT had come to California on an undocumented status, he did not have any insurance on admission, and his team's case manager applied for emergency Medi-Cal, which is California Medicaid, in the ICU. Despite needing rigorous post-injury rehabilitation, though, when he left the ICU, and despite his severe dysfunctions in cognitive, motor, and behavioral domains, his primary team started pushing for discharge when they were unable to find an initial rehab facility that was willing to accept him. So let's talk about TBI and structural vulnerability. TBI causes a substantial number of deaths and leads to lifelong disability for many Americans. In fact, TBIs contribute to about 30% of all injury deaths in the US. According to a CDC study in 2014, there were approximately 2.5 million TBI-related emergency room visits, approximately 288,000 hospitalizations, and nearly 57,000 deaths related to TBI. Not only is TBI a public health concern, but its treatment from ED presentation to outpatient rehabilitation can be significantly determined by an individual's structural vulnerability. So let's review what Dr. Khandai mentioned about structural vulnerability. Bourgeois et al. 2017 paper in Academic Medicine defines structural vulnerability as an individual or group of people being at risk for negative health outcomes through their interface with socioeconomic, political, and cultural normative hierarchies. So let's deconstruct that. Patients are structurally vulnerable when interactions of social, political, and environmental inequities in their society constrain their ability to access healthcare and pursue healthy lifestyles. This triangle illustrates the interconnectedness of these political, economic, and sociocultural factors that can lead to a lack of access to resources for patients. These overarching structures in our society lead way to inequitable access for resources for certain individuals and groups, which then leads to increased marginalization of these groups' healthcare and well-being. Ultimately, all these factors can converge and additively contribute to someone's structural vulnerability and impact rates of morbidity and mortality due to certain diseases or injuries. So let's start at the outsides of the structural vulnerability triangle and look at how these economic, political, and social structures can impact access to TBI care. We can first see structural vulnerability in TBI treatment due to social cultural inequities around race and ethnicity in the US. For instance, according to CDC statistics, American Indian Alaska Native children and adults have higher rates of TBI-related hospitalizations and deaths than any other racial or ethnic group. Factors that contributed to this disparity include higher rates of motor vehicle crashes, higher rates of substance use and suicide, as well as difficulties in accessing appropriate health care. Black and Hispanic American patients also tend to have higher rates of TBI and are less likely to receive follow-up care and rehabilitation following a TBI compared to non-Hispanic white patients. Racial and ethnic minorities are also more likely to have poor psychosocial, functional, and employment-related outcomes after sustaining a TBI than matched non-Hispanic white individuals. And some study outcomes relevant to our patient MT include that Hispanic Americans receive less intensive and fewer sessions of OT, PT, speech therapy, and psychotherapy than non-matched Hispanic white Americans. Hispanic Americans have less odds of placement in rehabilitation than matched non-Hispanic white Americans after adjusting both for injury severity and insurance status. And these examples demonstrate that race and ethnicity in the United States can impact the quality of TBI care an individual receives, even in cases adjusted for insurance or health variables. And then political structures that disenfranchise people of certain races and ethnicities will then further impact their ability to access TBI care. And then layer on top of that, unequal wealth distribution and lack of safety net structures. Those will also impact care. Now, we saw how existing structures can cause lack of access to TBI care. Moving inward in our structural vulnerability triangle, we see that differential resource access then leads to further marginalization. For instance, TBI survivors with lower incomes or who are uninsured have been consistently shown to have significant barriers in accessing appropriate TBI care, from ED admissions to inpatient care to rehabilitation, and consistently have poor outcomes for recovery. People living in rural areas also have a greater risk of dying from a TBI compared to people living in urban areas. Let's now look at Latino migrant workers in the US as our patient MT fits into this population. This population group is often undocumented and uninsured and are at a particularly high risk of experiencing health inequities. I believe this quote encapsulates the fragile status of Latino migrants in the US and multiple factors that lead to their structural vulnerability. Quote, "The vulnerability of Latino migrants is exacerbated by their interactions as economically disenfranchised laborers in a society that regards them as criminals and devalues their individual and cultural worth," end quote. Structural vulnerability is built into this specific group at several points. They often experience psychosocial traumas, oppressive policies, and socioeconomic factors in their country of origin, which end up leading to their migration. They will then often endure difficulties during their migration journey. When they reach their destination, structural disparities in the US all lend to increased risk of physical and mental health illness. And when at times these individuals are deported or voluntarily return to their country of origin, they can also find factors then leading increased stress on their return. Latino migrant workers in the US experience structural vulnerability across all social determinants of health due to political, sociocultural, and economic inequities. At the individual level, they have difficulty completing basic and higher levels of education due to obstacles in their country of origin and upon moving to the US. They are often coming from lower socioeconomic status in their country and have difficulty shifting that status when they get to the US. They tend to have tenuous legal status, are unfamiliar with the cultural norms that they move into, and will experience cultural and linguistic barriers to healthcare and health information, both in the hospital and in the community. They may develop substance use disorders or other mental health issues due to their migration and subsequent isolation. At a social and community level, Latino migrant workers in the US are often separated from their families, may experience social exclusion from other community members. They encounter xenophobia, discrimination, and stigma in their host communities, and there's often a lack of migrant-friendly health services. At a physical and environmental level, the living and working conditions Latino migrants experience are often unstable, including limited or lack of access to clean water and sanitation, unsafe or insecure housing, poor working conditions, and lack of occupational health protections, and access to or existence of jobs that provide a living wage. And finally, at a governmental policy and broader society level, there is a lack of legislation ensuring migrants' access to health, regardless of status. And depending on which state they live in, there may be ineffective or non-existent labor policies to protect workers' rights. So let's return to our case. As a reminder, MT is an undocumented Guatemalan migrant worker who suffered a severe traumatic brain injury and was admitted to hospital for initial treatment. If we look at his case through a neurobiopsychosocial model of TBI recovery, we can see that he has structural vulnerability from multiple domains that increases his risk of a poor recovery. From a neurobiological perspective, his limited educational status, particularly around safety and health, lead to a risk of higher injury burden. Furthermore, MT experienced chronic higher stressors due to multiple structural vulnerability components, exposure to trauma in his home country and during migration, his fear of deportation, housing and food insecurity, and a poor working environment all led to increased stress. Chronic stress can impact immune status, increase other health risks, and change recovery factors before an injury ever happens. And from a psychosocial perspective, all of these chronic stressors can have pre-morbid and post-injury impacts. Environmental and socioeconomic factors play a huge role in the success of MT's recovery as well. Now for MT, his insurance and socioeconomic status made it impossible for him to be placed in a rehab facility. He had insecure and unsafe housing for TBI recovery, as his team kept trying to discharge him to a single room to live in with his brother and another roommate, both of whom worked full-time. He had limited access to assisted transportation, thus limiting important rehabilitation appointments. He initially had an extremely limited social support network to help with recovery, until our team began involving ethics and risk management to engage around finding safer discharge alternatives. Lastly, caregiver factors played a big part in his recovery. MT's brother had been identified as his main caregiver, and he himself was an undocumented migrant worker with similar educational, language, and cultural barriers. MT and his brother both experienced significant cultural stigma with some of the medical staff and had poor access to interpreters, which was witnessed by our team at multiple points. In his case, it became the role of our team to act as advocates for the patient and his brother, to insist on a safe discharge plan, to involve ethics, to help arrange in-person interpreters and regular family meetings, and to provide education to both MT and his brother. In the end, we were able to have the patient stay in the hospital longer for rehab and identify and involve additional family members and a safer discharge location with cousins. However, MT was still never connected with an optimal rehabilitation option. He was left to do home rehabilitation with follow-up appointments instead. A crucial part of our role as CL psychiatrists consulting on MT was to understand his structural vulnerabilities and use that understanding to educate his other team members on how these vulnerabilities could impact his recovery, as well as advocate for more services and resources to optimize his treatment. Now, in the academic medicine article we mentioned earlier for the definition of structural vulnerability, Bourgeois et al. Detail an excellent structural vulnerability assessment tool, the domains of which are outlined here on this slide. In doing a complete structural formulation for a patient, you want to use this tool or something similar to recognize social and structural impacts on clinical interactions with patients. Now, this tool operationalize is a means to intervene on negative health effects of the social determinants of health. And you can use this tool or similar questioning to think about multiple levels of a structural intervention. So on an individual level, you can assess yourself, see, do you have a personal bias against a patient? If so, are you able to become aware of it and actively resist it? On an interpersonal level, we can educate other providers and trainees to use these tools and to recognize and address biases that are impacting care. On a clinical and institutional level, we can intervene on whether there are sufficient people providing transition, training for residents, fellows, and other staff in cultural competency and recognizing structural vulnerabilities. On a community level, we can connect with members of the community to ensure transition of care and provide ongoing education. And on a policy level, we can advocate for changes in insurance coverage, healthcare rights, working rights, and other things impacting patients for like MT on a structural perspective. Now, in conclusion, our patients' recovery lie not only in their inpatient and outpatient medical course, but in the socio-political, economic, cultural, and environmental inequities that influence their ability to care for their daily well-being. These inequities are the components of their structural vulnerabilities. As CL psychiatrists, we are uniquely positioned to assess how structural vulnerability impacts our patients. We can then liaise with our colleagues and other treatment teams, as well as with patients, their caregivers, and communities to provide structurally informed care. Educating trainees in cultural vulnerability assessment and structural humility is an important step in advocating for our patients' health and well-being and training the next generation to continue to be able to do that work. Thank you so much. I'll now turn it over to Dr. Taylor.
Hi, I'm Dr. Adrienne Taylor, a CL psychiatrist at Brigham and Women's Hospital in Boston. In this part of the talk, I will be discussing a case highlighting the intersection of law enforcement and the healthcare system in a young Black Haitian male with schizophrenia. I have no disclosures. After discussing the case, we will highlight the use of lethal force by law enforcement nationally and the resulting consequences to the healthcare system. We will also study the ubiquitous presence of implicit bias and analyze how to use the concept of procedural justice to provide equitable care of trauma patients who have had interactions with the police. Finally, we will return to the case to tie all of these topics together to focus on how CL psychiatrists can approach their patients using this social justice lens. So for the case, a 37-year-old Haitian Black male has been transferred to your facility from an outside hospital from sustaining several gunshot wounds to the abdomen following an encounter with the police. When he arrives, he is found to be intubated and sedated and taken directly to the OR for further surgical revision. After about 3 weeks, Mr. M remains medically unstable after additional surgical repair by the trauma service. You are consulted giving ongoing altered mental status after extubation, history of underlying psychiatric illness, and evaluation for need for psychiatric medications. At initial presentation, he is non-communicative and stuporous. His mother cannot be reached for collateral, and information from the nurse at the bedside is that his mother is rarely there. When she does come to the hospital, she often presents with her priest, and they spend most of their time praying over her son. He remains in the surgical intensive care unit for the next month due to ongoing management of devastating pancreatic injury, which will require a long duration of recovery and need for extensive reconstruction, which will be delayed for at least 6 months. Police accept a request for compassionate release, given poor medical status and prognosis. An ethics consult is requested by nursing staff due to the concern for prolonged suffering, given history of untreated psychiatric problems with long history of non-adherence. There was also concerns from mother's hope for divine intervention, causing pressure for ongoing heroic measures. By this time, further history has been obtained regarding Mr. M. He was born in Haiti and moved to the United States with his mother and sister at age 4. He attended college and studied art and design. However, he started to develop psychiatric symptoms in his early 20s, resulting in several psychiatric hospitalizations and him dropping out of school. He's been non-adherent to psychiatric treatment and has not been seen by his treatment team for several months. His mother currently works 2 jobs to support them, and he has had at least 1 previous incarceration and an admission to a forensic psychiatry unit. The family is deeply religious and have always relied on their faith and spiritual leaders for support. By the 3rd month of hospitalization, Mr. M's mental status is greatly improved. He is more alert, awake, and able to engage in interview and care. He admits that he had self-discontinued his psychiatric medications and been in the midst of a psychotic episode with paranoia and command auditory hallucinations when he was injured by the police while he was in a cell phone store. He adds that he had decided to pursue suicide by cop to end his internal suffering. During this hospitalization, he continues to experience hallucinations and notes motivation for ongoing treatment and further trial of antipsychotics. He also requests to be full code and reiterates his deep faith. His Department of Mental Health team was contacted for further coordination of care and disposition planning, given his high risk of recurrence of psychiatric symptoms, potential legal consequences of this psychotic episode, and post-trauma support. He is eventually transferred to the floor with ongoing poor nutritional status, low GI motility, and variable ostomy output. Mr. M is started on intramuscular paliperidone with significant improvement in paranoia and his auditory hallucinations. The surgical team remains dedicated to his recovery, deciding to continue hospitalization until revision surgery due to his need for close monitoring during rehabilitation. 6 months into the hospitalization, though, the team is alerted that Mr. M's bail status has been revoked due to an elopement risk and increasing independence and mobility, causing significant stress to several team members who have been dedicated to assisting in his recovery. He is again placed in police custody, and 2 officers return to the hospital and immediately place him in hard restraints. The psychiatry service plays a key role in discussions with the House of Correction leadership to develop a plan to allow for ongoing recovery while in the hospital and participation in physical therapy and proper handoff for his transition to the criminal system. Given the start of the COVID-19 pandemic, however, Mr. M is discharged to a prison unit at a local rehabilitation center. His mother, with support of his DMH team, is also able to obtain guardianship to allow for further oversight and support as he starts his long road to recovery. So although this case highlights several disparities in healthcare, including race, immigrant status, religion, history of serious mental illness, incarceration history, and socioeconomic status, not to mention the start of the pandemic affecting disposition planning, we will spend the remainder of this talk highlighting the impact of race, serious mental illness, and incarceration status on how we perceive and work with patients within healthcare. So the case here is not an uncommon one, and many of you will be able to recognize similarities in this case in recent shootings that have been highlighted in the news or that you've encountered in your own practice. Major acts of civil disobedience and unrest have arisen in the US in recent years in response to concerns about police use of force, often resulting in long-term health and economic consequences for affected communities. In addition to issues of racial and social inequality, concerns about the risk of vulnerable populations, including individuals with mental illness, have also been raised. Law enforcement agencies frequently serve as first-line responders to mental health emergencies, including crises involving violence. And about 20% of people hospitalized for severe mental illness have also been arrested or picked up by the police for a suspected crime during the 4-month period prior to their admission. The use of lethal force in many cases reflects the risks inherent in policing and the duty to mitigate immediate danger to the public and police personnel. However, there is an increasing recognition that lethal force, even when considered justifiable from a legal perspective, is oftentimes preventable and costly. The estimated lifetime medical costs to injuries and fatalities that has been found to total about $230 million. Blacks experience increased frequency in police contact, higher rates of arrest, and use of force when compared to whites. But there has been little evidence found to account for the difference in the frequency of most forms of police contact. Deaths caused by lethal force occur at consistently higher rates among Black men compared to white men, with rate ratios ranging from 2.6 to 10.1. Estimates also suggest that 25 to 50% of fatal encounters involve individuals with mental illness. In a study looking at rates of fatalities due to the use of lethal force by law enforcement, DeGuy and colleagues examined data from the National Violent Death Reporting System from 17 states over a period between 2009 and 2012. Blacks were 2.8 times more likely to experience a legal intervention death, were more likely to be unharmed, and significantly less likely to pose an immediate threat to law enforcement compared to whites. 1 in 5 legal intervention deaths was directly related to issues with the victim's mental health or substance-induced disruptive behaviors. And in these cases, they were less likely to be precipitated by an alleged crime and less likely to involve injuries to law enforcement officers. 17.9% of cases were identified as potential suicide by cop incidents, as based on evidence that the victim was suicidal or engaged in behavior to elicit the use of lethal force. These cases were significantly more likely than others to involve an intoxicated victim who were often armed with a weapon. Although victims with evidence of psychiatric illness, substance-induced disruptive behaviors, or suicide by cop behaviors were more commonly white, This may reflect in part racial differences in trust and perceptions of the police and significantly higher rates of suicide among white men nationally. Racial inequities in lethal force cases may reflect differences in the way that some law enforcement officers or agencies perceive and interact with the Black community. Most people hold culturally derived implicit biases, which as previously mentioned, are attitudes or stereotypes that affect our understanding, our actions, and decisions in an unconscious manner. Research on implicit bias in the US consistently demonstrates a tendency to associate more favorable concepts with whites and less favorable concepts with Blacks across racial and ethnic groups. These biases can impact behavior even among trained professions such as physicians. Although overt discriminatory behavior in the US may have declined in recent decades, covert discrimination and institutional biases continue to be present and influence provider behavior and treatment choices. This may also contribute to health disparities. Within the general population, significant research has found that associated negative valence and certain feelings such as fear and distrust with Black Americans tend to be automatically activated and applied most often when people are busy, distracted, tired, and under pressure. As physicians, this is a frequent state of being for us, given our clinical responsibilities, administrative roles, and personal obligations. You may find that the cognitive effort to assess and process a person's individual characteristics appears to be greater than that required to quickly characterize a patient into a particular group with a particular characteristic. While these shortcuts in thinking may be useful in certain situations, it may have been strengthened in our own medical training. Providers should strive to establish genuine working relationships with their patients and deliver equitable healthcare. As we frequently encounter on our own work, implicit biases against patients with serious mental illness also affect their interactions with the healthcare system. This is further compounded when patients have several characteristics or features that result in discrimination or oppression, as highlighted in previous discussions of intersectionality and in the case presented here. People with mental illness are more likely to be perceived as dangerous, leading to increased social distance amongst providers. This fear and avoidance of people with mental illness may influence acts of discrimination amongst providers and lead to decreased recovery of or maintenance of treatment goals. So when addressing implicit bias is never easy. It can be especially difficult for physicians to contemplate the possibility of harboring unconscious attitudes or stereotypes. As more healthcare organizations work toward achieving equitable care for all patients, it is not enough to focus on intentional discrimination. We must also acknowledge implicit bias and address it. As mentioned before, the implicit bias test is the most recognizable measure used to identify an individual's implicit biases. Just this knowledge alone can allow people to think critically about whether these biases are in line with their principles. Additional actions can be taken to reduce implicit bias, including individuation and partnership building. Remember, resisting implicit bias is lifelong work. We have to constantly start the process over and look for new ways to improve. So adding the aspect of trauma along with race and mental health further contributes to intersectionality for Mr. M and patients like him. These groups can often be disenfranchised from the healthcare resources needed to support their physical and psychological recovery. Healthcare providers may again have their own implicit biases, often stereotyping these injured patients as perpetrators rather than victims of violence. The presence of police within the healthcare space may further reinforce deviant and criminal stereotypes of injured patients and interfere with their ability to feel safe in the hospital setting, causing them to feel disenfranchised and causing concern that the hospital environment itself has been compromised, when rightfully or not, they are held accountable for the cause of their injuries. It is important to remember that patients are at the center, and they may interpret police interactions before and during hospitalization as inappropriate and dehumanizing. Development of disengagement and distrust among patients from disenfranchised groups may also contribute to long-term racial disparities. After injury, including risk of re-injury, higher rates of mental health disorders, and the use of risky strategies like substance use to cope with the physical and mental aftermath of injury. Police officers have a unique set of responsibilities, with their primary concern being for public safety, as they focus on investigating and preventing crime. Their presence can be prolonged and constant, especially when the risk of the patient is decided high enough for them to remain in police custody. On the other hand, the physician-patient relationship is as complex as it is critical for medical professionals who provide care for victims of trauma. As soon as the clinical relationship with the patient has been established, the patient's interests and safety become the physician's primary concern. This responsibility is both an ethical and a legal duty. It applies to all patients, including those who are suspected or convicted of a crime. Safeguarding the health, autonomy, and dignity of a patient remanded to police custody should be the primary focus of the physician. Although the relationship between the healthcare system and law enforcement can often be mutually beneficial, law enforcement's presence may distract from and negatively impact the quality of care provided to the patient when police and the medical team have conflicting goals. Such differences can place the care team in difficult situations as they attempt to manage a patient's care, particularly when the patient is an extremist or needs emergent procedural intervention. Procedural justice is a concept from legal proceedings that speaks to the idea of fair processes and how people's perception of fairness is strongly impacted by the quality of their experience, and not only by the end result of these experiences. When a clinical provider dedicates themselves to providing the most equitable care to a patient, this focus can be strengthened by considering this concept. Procedural justice is critical for building trust and strengthening the physician-patient relationship. It can also further an organization's effort to restore strained community relationships by laying the groundwork for legitimacy and fairness. When striving to provide fair and equitable care with victims of trauma in police custody, it is important to remember the 4 pillars of procedural justice: neutrality, respect, trustworthiness, and allowing for patient voice. While it is important to have the pillars of procedural justice in mind when assisting in management of patients in custody without policies and procedures in place, remember that implicit biases will continue to be present, and the behavior of hospital staff may lead to unintended, informal, and even illegal access to patients and disclosures of their health information to law enforcement. This can also promote interprofessional conflict and negative clinical outcomes. There is an opportunity to articulate the need for boundaries and necessary considerations when law enforcement activities take place within U.S. trauma centers. This will allow for the protection of injured patients, clarify professional role expectations, and prevent conflict. It would also better prepare legal counsel and ethical consult teams to support clinicians in cases when policy interpretation is difficult. Jacoby et al. Have recommended core policy goals to assist hospital systems in cross-disciplinary collaboration to develop policy in an ethical way that protects the rights and well-being of patients, healthcare providers, and the public. Educational efforts around these policies should explicitly incorporate an explanation and understanding of the role of race and structural racism in healthcare and law enforcement, and the roles of police and healthcare providers in perpetuating these structures. So as we return to the case, it is important to remember that as a CL psychiatrist, we are best suited to apply social justice principles, particularly implicit bias and procedural justice in the clinical setting, given our embedded role within the larger medical system. For Mr. M, the CL psychiatrist was crucial in discussions with the surgical team when they encountered and worked through their implicit biases about a Black man with a history of psychiatric illness, incarceration, and recent violent encounter with police resulting in legal consequences. We were also able to provide a framework using the pillars of procedural justice to provide equitable and fair care and disposition planning given the ongoing presence of the legal aspects of the case. We should continue to work towards social competency to promote and restore equity for patients at the intersection of psychiatry and general medicine. Next, Dr. Kayla Bebahani will discuss a case highlighting the principles of structural competency.
Hi, I'm Dr. Kayla Bebahani, and as we continue to explore social justice, we're going to discuss structural competency as it relates to a trauma survivor and an invasive procedure. No disclosures or conflicts to report. So we're going to be talking about the case of Ms. L. She's a 40-year-old female, has a history of depression, anxiety, and PTSD. She presented to her PCP with fatigue and bruising and poor motivation. CBC revealed mild anemia and thrombocytopenia, but her condition unfortunately progressed, and ultimately she was diagnosed with aplastic anemia with PNH clone. She began the NIH treatment, but her condition continued to progress and plans were made for a bone marrow transplant. A lot of her friends and family were tested. They all volunteered to help. And ultimately her brother turned out to be a match, and plans were made for the brother to be a bone marrow donor. She was admitted to the hospital for stem cell transplant. She received a conditioning regimen and GVHD prophylaxis, which is pretty standard. Following the conditioning regimen and 1 day prior to the transplant, she became very anxious, very tearful, couldn't really verbalize what was going on, but her primary team felt that maybe she had cold feet about the transplant. And so they put in a psychiatric consult for medication recommendations due to severe anxiety. I was the psychiatrist who saw her, and upon my evaluation, she was still tearful. She was in bed. She had the covers drawn over her face, didn't really want to talk, said that she didn't want to say what was going on, didn't want to talk to anybody, and just preferred that I leave. As I began to leave, she changed her mind and said that she had a problem that she actually needed to talk through and figure out, and she needs somebody to listen to her and help her work it out. So over the course of the next hour, she revealed that she couldn't go through with the transplant because the donor, who happened to be her brother, had sexually assaulted her when she was a young girl. As you can imagine, this opened a whole level of complexity that no one was expecting. She said that she initially didn't object to the transplant because she was afraid that if she did object, it would invite all sorts of questions by her friends and family, and they didn't know what had happened to her. She didn't want to admit what had happened to her. She hadn't even told her primary team what had happened to her. And so in her mind, she would rather go through with the bone marrow transplant she really didn't want to go through with, rather than admit what had happened to her. She said that she felt very ashamed. So in general, before a bone marrow transplant, there's usually a social work consult and a social work evaluation. As part of the psychiatry consult, I did review the chart pretty thoroughly, and I did find the social work evaluation both before the hospitalization and also during the hospitalization. The evaluation during the hospitalization was done by a social work intern, but regardless, it was a pretty good evaluation. It was pretty thorough, and it was well documented that the patient did have a trauma history in childhood. The specifics of that trauma history were not detailed in the note. Obviously, many of us don't put those types of details in the note, but there was mention of a trauma history in childhood. Now, most of us are familiar with this. We learned it in medical school. We, as psychiatrists, learned it throughout residency. We know the consequences of adverse childhood events. We know this has been thoroughly studied in our field, and it's in the back of our mind whenever we meet a patient with a trauma history, especially one who has PTSD or who has suffered throughout their life because of their trauma history. But the rest of medicine doesn't necessarily get the same education that we do, and they may not be as familiar with this. So in terms of Ms. L's past psychiatric history, she did have a history of depression and anxiety, as we talked about. She had no psychiatric hospitalizations in the past. She did have one suicide attempt by overdose. That was in the context of familial conflict. She did have a longtime therapist, and she was prescribed both Prozac and Effexor by her PCP. That is a pretty unconventional regimen, but because she was there for the bone marrow transplant and because of what else was going on, I didn't really feel a need to change it, especially as it had kept her mood stable for so many years. So I did not touch her medications. She also obviously had a history of childhood trauma and sexual violence. Oh, and one other thing, her social history, she does live at home with her partner and kids. And just to note, the abuser in this case, who was her brother, did not have access to the children. So there were no safety concerns with regard to the children. So these were her labs on the day of the psychiatric consult. Now, again, this was after the conditioning regimen and 1 day prior to the transplant. So as you can imagine, this is pretty alarming for a patient who does not want to go through with the transplant. And this is why the primary team was so concerned as well. So I think we need to explore, how did we get here? How did we get to the point where this patient went through all the steps one would go through for a bone marrow transplant, and then at the 11th hour, she changes her mind and decides that she actually doesn't want the transplant after all. Again, we have to talk about the social work consult and mention of trauma history. Notably, none of the notes from the primary team actually mention this, although PTSD is part of her problem list. I think one reason this is so important is because when the patient finally shared this news with me and I spoke with the primary team, some of them were not aware at all of a trauma history in the patient. It was the first they had actually heard of a trauma history, let alone why she did not want this particular transplant and the relationship between herself and the donor. So that brings us to structural competency, and how does this particular case relate to it? So once again, we'll review the definition of structural competency, trained ability to discern how a host of issues defined clinically can have downstream implications of a number of upstream decisions. So what we're talking about is an approach that not only promotes, but also acknowledges factors that affect patients' health and health outcomes on a larger scale than just the individual interactions. It emphasizes 5 core competencies, which we're going to take a look at one at a time. And just to clarify, when we talk about structural competency, structure can actually be in reference to any number of things, from laws and courts to economics and politics and schools. For the purposes of this part of the presentation, we're going to be talking about structure and how it relates to clinical and biomedical structure. So we're talking about hospitals, we're talking about the biomedical system, we're talking about US healthcare and healthcare delivery. All right, so the first core competency is recognizing the structures that shape clinical interactions. So like I said, we're going to be talking a little bit about the hospitals, and we're talking about healthcare delivery as well. In this case, obviously, there were a number of people involved in the patient's care. And we know, I mean, there's been literature on this, we know that a team-based approach tends to lead to better outcomes for patients. However, we must also take into account that when you have a number of people involved in a patient's care, things can get missed. Things can fall through the cracks, which is exactly what happened here. When the evaluations are completed by different teams, such as the primary team or social work or psychiatry, those teams may not be privy necessarily to the medical and psychosocial factors of the case that can overlap and significantly impact others. A few things to keep in mind also about this particular case is other things that, other components of it that may have led to the outcome in the end were gender and psychiatric history, which we're gonna also talk about in a little bit. Race and socioeconomic status didn't really play a role here, but they very clearly can play a role in other patient outcomes. All right, so the second competency we want to talk about is developing extraclinical language of structure. So what does that mean? So we're going to be talking about what happens before the patient actually even gets there. Now, I know I said that we're going to be focusing on the hospital and we're going to be focusing on biomedical education and systems, but pre-medical diagnosis, pre-admission, what was going on in the patient's life that may affect the clinical course is also very important. There's a lot out there about social determinants of health and health disparities as a function of socioeconomic and sociopolitical structure. We also have to consider stigma. Stigma played a huge role in this particular case. Remember, one of the first things the patient said was that she would have rather gone through with the transplant than face the stigma of admitting what had happened to her as a child. The stigma against trauma, rape, incest, all of these things made her feel ashamed. And that's why she didn't raise any red flags and why she went through with the tests, with the conditioning regimen, thinking that she could go through the transplant because admitting what had happened to her was actually so much worse in her mind. And then, of course, gender dynamics played a role because of physical and historical disparities, which also relates back to sexual violence and trauma. So re-articulating cultural presentations in structural terms. And, you know, it's really important. Cultural is in quotes. The implications are different depending on the patient. Because certainly what's going on with the patient is what is going to affect how you look at this particular core competency. Here we're talking about medical protocols. We're talking about a medical system that doesn't really allow the primary team to get into the nitty-gritty about the patient's trauma history. Have they been trained to do that? I'm not really sure beyond the medical school training that we all get, but also from a time standpoint, an objective standpoint, and what their role is. That's why social work is involved. That's why psychiatry is involved. So the primary team really didn't explore that at all, nor did they actually explore any of the potential conflict in the familial relationship. What could potentially be going on between the patient and her brother, their relationship in the past, how things stand between them right now. They didn't get into any of that. And also an important part of this too is a trauma survivor's care when they're undergoing an invasive procedure. That also definitely played a role in this as well. And the fourth competency, observing and imagining structural intervention. So this is where we get to talk about what could be done differently. This is an expansion of what we had talked about earlier. You know, as CL psychiatrists, we're consulted on these cases. What teaching points can we offer to the primary teams to help beyond just medications, beyond just recommended treatment plans? How can we help them to approach some of these cases, and what impact can we have on patients like Ms. L with the theory of structural competency? What benefit does it have in this case? So in her case, a team-based approach, we want to take a team-based approach and explore and understand the psychological impact of the invasive medical procedures, which we just mentioned. You know, we've heard the term healthcare trauma all the time, and as psychiatrists, we're well versed in it, but we shouldn't take for granted that other specialties are as well. We're educated on it, we read up on it. Do we really learn what it means in medical school? That standardized education that we all get, we don't really explore it, not until we're in our specialty and in our residency. Our colleagues likely are not getting that same education, so we can't take for granted they know as much as we do about it, which is what makes us such valuable consultants as well. We also want to talk about the family relationships. We talked about the primary team. They didn't really get into the family relationship, potential toxicities there. But what also happens in families when the healthy sibling is called upon to help the sick one? What does that do to the family dynamics? What does that do to the relationship between the siblings? And of course, is there a history that can potentially complicate things? That was something that was ignored in this case. And it, I just want to say, in this case, it's pretty dramatic. I mean, most of the time you're not going to get a patient like this, but there are a number of cases where family conflict or potential betrayals between siblings can result in similar outcomes. So just because the history may not be as dramatic as in this case, I don't think that we can take for granted any type of conflict or any type of relationship between siblings that may present a problem down the road. We also want to talk about PTSD and how hospitalization and invasive procedures may make a patient who already feels potentially vulnerable, how it can affect them, how it can potentially worsen things for them in the acute setting. There's obviously a power dynamic at play in the hospital, and understanding what that can potentially do to a trauma survivor is really crucial in preventing cases like this. And then finally, can we design a structural intervention that includes team-based trauma-informed approach from admission to post-discharge? And then finally, the last competency is developing structural humility. So this one is all about recognizing our own limitations and the limitations of the clinical structure as well. In the case of Ms. L, every person involved in her care, from nursing to oncology, social work, to psychiatry, myself, we all had our limitations. And whether that was due to our own countertransference or never having seen a case where a patient was at such high risk of death due to unforeseen psychosocial complications, or just being unsure how to approach trauma patients in general. We all had our limitations, and this is where medicine is really a team sport. We need to call on others who can potentially help us with these cases, certainly, but we also need to identify our own limitations and identify the limitations of the institution as a whole. Unfortunately, the primary team in this case didn't have a lot of information about the potential complications that could arise. The information in the social work note, like I said, was pretty vague, and there was no conversation between the primary team and social work about the specifics of this patient's trauma history. Is that a limitation of the institution? Is it a limitation of the way we deliver care? Or is it really just a limitation that could potentially happen regardless in any setting, any healthcare setting, whether it's in the US or somewhere else? Unfortunately, it can be a consequence just of what we do every day. So as we return to the definition of structural competency, I just want to give an update on what happened to Ms. L. So if you remember, the team was concerned because she had undergone the conditioning regimen and decided at the last minute that she could not go through with the transplant. She was very fortunate, actually, in that the regimen she was given did provide for a decent chance of count recovery relative to other treatments. Had she been treated with myeloablation, for example, she likely wouldn't have had as good an outcome. So she was hospitalized at our facility for an additional 2 months. Then she was transferred to a hospital closer to home, and she continued to await count recovery and guard against opportunistic infections. And then I lost track of her after that, but the team was hopeful, especially after she made it past the 2 months, that her prognosis would be good. So structural competency is a relatively new area in medicine. It's been recognized and implemented in certain general psychiatry programs. There's still a lot of work to be done before it can be implemented on a wider scale. Really, this can be said for all of social justice. One of the things that we're hoping that you take away from this is that there are a lot of people eager and willing to do work in this and to help to implement it on a wider scale. And with that said, I'm going to throw it back to Dr. Kambi, who is going to lead us in a panel discussion.
Thanks, everyone, for joining us for these cases, and special thanks to my colleagues for guiding us through CL cases from a social justice perspective. Now we're going to discuss how to support social justice in CL through a panel discussion. We have this ongoing survey of psychiatrists, including CL psychiatrists, about social justice, and these are some questions that have come up that we wanted to discuss further for the remainder of our time. So the first question that's come up is, how can psychiatrists further educate themselves on social justice? So team, what do we think?
More and more resources are becoming available every day. So I think part of it is being proactive and looking for those resources, looking for those journal articles, and reading as much as you can about social justice in general, but also how it relates to medicine and how it relates to psychiatric care as well.
Yeah, and I think like starting off and listening to a talk like this one is really helpful in giving yourself a sense of what the basics are. And then like taking that as a jumping off point to starting to have conversations amongst yourself, with your family, with your friends, and even with your colleagues about some of the topics and some of the things that we've discussed here today. And I think that by starting those conversations, it will kind of really help you start to think about where you yourself lie and where your principles lie, and then it will lead you to different resources as you move forward.
In terms of a couple concrete ones, I know we have a really great resource linked at the end. SAMHSA also has a wonderful behavioral health equity page. That's a good landing point to start and look at links. And there was a book that just came out from APA that I would recommend called Social Injustice and Mental Health by Ruth Shim and Sarah Vinsum, that I think is a great book as a starting point looking at different levels of social justice.
And as everyone has mentioned, I know it can seem daunting when you're at the start of confronting really challenging topics and something that can be a new area for some that to go down this path, and all of these resources that are already available, that it's not just us as psychiatrists or CL psychiatrists that are grappling with this, that all of the major medical organizations are grappling with this, government bodies. So the ADAMSEP resource that we've linked to is a 28-page document that goes into what is out there at the time that they did this needs assessment, excellent needs assessment from Dr. Francis Liu. And so looking at psychiatry, what training modules are there, what government resources, what other NGOs. And so there's a lot of work that's being done in lots of different places by lots of different people. So just kind of picking any one of these as a jumping off point can be a place to start. And there's not a wrong place to start, just to lean in and go.
Excellent. So the next question that came up was, on a related note, what can I do on the individual patient level to advance social justice?
I think what I found with my case that I discussed is, and it was a long time that we followed him, was the importance of that liaison role and to be an advocate and to use your liaison powers as a CL psychiatrist to really be able to advocate with teams, to educate teams, to educate your trainees, to reach out to ethics, to risk management, to help with those community transitions. And this is true, right? Whether you're an inpatient CL psychiatrist or you're in the emergency room or you're outpatient, there are lots of opportunities to advocate for patients and, think about what are their social determinants, what are the stigmas that they're facing that are impacting their access to care, and really help them to navigate those aspects of their care.
And keep in mind too, I think it's really important to keep in mind that it's not always that the primary team, I want to say it's never really, that the primary team doesn't care about some of these social justice tenets and what's going on with the patient. Most of the time, it's that they just don't know. And as Mira said, that's where the liaison part of consultation liaison really comes into play. It's about teaching, and that's how you advocate for the patient, and that's how you advance their care within a social justice framework.
Yeah, and I think one of the things is like remaining active. I mean, as Dr. Zane said, along with my case, this patient was here for a very long time. And so there wasn't always, day-to-day active psychiatric management that we were doing, but it was kind of more behind the scenes work that we were doing with the primary team, the social work team, the trauma liaison team here in the hospital, and making sure that the patient was getting all the appropriate care and support that we could provide them outside of what was going on with kind of the day-to-day surgical management and psychiatric management.
one of the great things about being in CL is regardless of your treatment context, if you're on the standard inpatient teaching team or more embedded in an outpatient clinic, that directly with patients or with peers or with trainees or teams, these are all potential points. And one concrete low threshold thing that I like to do, since we're always looking for bite-sized learning opportunities when you have a free minute, is conceptualizing cases like we did with our case presentations in terms of thinking about the cultural context, thinking about the biases, thinking about the ways that systemic racism are leading to health disparities. And so I think that you can even take this opportunity to do this with one case that has really good examples when you're doing your teaching rounds or bedside rounds or walking from place to place. So I make a conscious effort for each group of trainees that comes on my service that I make sure that I've talked about all of these concepts, and we have lots of opportunities to highlight these issues.
All right. Well, related to question 3 is, how can my institution support social justice in CL?
I just have to say exactly how Dr. Robinson said. Wouldn't it be great if CL services around the country started implementing that, where it was part of their teaching tools and part of their teaching didactics as well, that when a consult comes in, they try to conceptualize these things together, learn from each other, talk it through together, kind of like we did in preparation for this presentation. I think that would be really important.
I think, as we all mentioned, like, CL psychiatrists really do have an embedded role within the system. And with that embedded role, it gives us the opportunity to engage with a lot of different people, and even like hospital leadership within our institutions, and start to have these conversations. And a lot of times, like everybody said, that they might start off with a certain case that everybody's kind of come around to work on and support the system. But from that case, you can start to talk about, well, these are some of the inequities that we not only see with this patient, but this is some of the inequities that we see with other patients. And so what is it that we can do about these inequities, like, moving forward?
I would say also looking at what are existing things that are at your institution, potentially not in CL psychiatry, but might be able to be worked with in an interdisciplinary fashion. So, for example, at my institution, there is an interdepartmental QI project going on in the emergency room on access to transitions, to hospitalization after someone is put on a psychiatric hold. And that was something that was started by the emergency room, and psychiatry, CL psychiatry was pulled in. So I think knowing what things are doing, what things are happening with the diversity, equity, and inclusion department for your hospital, for your specific department, in other departments, what things can you pull in there? And another thing is, as our survey rolls out, to take the survey, and it gives you a good sense of, what are the things that we have or haven't done. So we hope that you guys do fill out the survey when it gets to your institution.
That a lot of institutions have started this work too. So as Dr. Zane mentioned, that both within psychiatry and looking across departments, that a lot of institutions like my own here in Dallas are doing surveys of faculty, of residents, in terms of where is the knowledge basis now? What kind of programming do they want? How are we going to effectively be able to incorporate this into existing curricula, standalone lectures, grand round speakers? And so really incorporating these things as threads and not just as standalone lectures, that we've learned that, again, that this has to be across the learning continuum from trainees as well as faculty.
Excellent. So moving on to our last discussion question. Ostensibly coming from as a researcher, I'm a CL researcher. What can I be doing from a research perspective for CL?
So I think the question is, what can't you be doing? Because there's actually so many opportunities and so many ways that you could potentially be contributing to this, since this is such a new and burgeoning area. So I think QI is actually a great place to start, to look at specific cases and be able to break down what might be happening. I'm sure you can pretty much find anywhere, whether it's in the ICU or in the emergency room or on general floors or in outpatient, that there are places where this becomes really important. I think a couple examples that come to mind, the QI project I mentioned earlier that we're doing in the ED, but for instance, I do integrated behavioral health on the outpatient setting. And there's some great research that is starting to come out looking at access to care for different racial and ethnic minorities. When you use integrated behavioral health to improve that access. So there are lots of opportunities to think about what a problem you're trying to solve. So if you're trying to improve access for a specific population, or if you're trying to decrease the number of PRNs being used in the ICU for people of color, how can you think about studying that and converting it into a project?
And forensics too. I think forensics is another area that if you have any interest whatsoever in forensics, we need more research done on social justice issues in forensic psychiatry. I think it would be very, very helpful for the field.
Okay, well, thank you all. Some take-home points we have for you as a group. Just remember that psychiatric patients are underserved in general medical needs, and minoritized populations are underserved psychiatrically. Remember that CL is uniquely positioned to address social justice given our embedded and systems-based roles. Remember to reframe consult questions and assessments from a social justice perspective so we can best help our patients and colleagues. And finally, social justice can be addressed on many levels, as we've been discussing, educationally, on the individual clinical level, institutionally, policy and advocacy, and with research. So before we end, here is a high-yield resource from Adam Supp, which has a comprehensive compilation of professional organization websites, foundations, online training resources, department training programs, books, and films. Thank you all so much for joining us for our talk today. We hope that this can be the beginning of your journey into social justice in CL psychiatry. Thank you all.